generally doing IIT is the most common cause of the death worldwide. Coronary angiography remains the gold standard for diagnosis of IIT. Coronary angiography is extensively used. It has access to entire coronary anatomy. It is cost effective, good positive predictive value, and easy visual interpretation. But it's not 100% accurate. It's not what you see isn't always what you get. There are many limitations of coronary angiography, which is highly subject to investigations. Eccentric lesion can be misinterpreted in coronary angiography. It doesn't give any information of vessel wall. It is indirectly it is a luminogram only. It only tells about artery lumens. Intermediately severe luminal narrowing, which has 40 to 70%, cannot be accurately determined. For example, I can say this lesion is 50%, other interpreter may say it is 70%. Artifacts of contrast streaming can be there. Vessel force shortening phenomenon can be there, which I explained later on. Overlapping of side branches, particularly in bifurcation, can be misinterpreted the findings, and limited correlation with physiologies. Here are some limitations of coronary angiography. Here you can see eccentricity of lesion. In image A, you can see here is a plaque which covers almost 80 to 90% of the area, but it is eccentric plaque. When we do angiography in RAO and LO projection, we can't find any plaque here. It can be misinterpreted in coronary angiography. In second image, you can see eccentricity. Here you can see eccentric plaque. And during specific projection, like RAO projection, you can see there is no stenosis, but in LAO projection you can see minor stenosis, but actually it is very severe lesion.
It is not possible.
Yes.
There is just a diagrammatic representation. બાકી RAO માં આટલા બ્લોક હોય જેમાં તમે રેસ બતાવ્યા છે
એટલે પેલી જે ડિરેક્શનમાં પ્રોબ જાય ને તો બતાવ્યું છે કદાચ એ
when plaque is eccentric, contrast flow from here to here only.
Suppose the plaque is eccentric.
Yes.
RAO and LAO, they are perpendicular to each other.
Yes, sir.
Okay. હવે perpendicular to each other જ્યારે બે પ્લેન થી તમે ડાયમેન્શન તમે જ્યારે જોતા હો, ઇમેજિંગ કરતા હો, ત્યારે એકમાં કદાચ શક્ય બને પણ બીજામાં ના જ બને. It's not possible. That is why ત્રણ વ્યૂ લેવાના હોય છે.
Yes, yes. But in some eccentric plaques having more than
this is wrong. RAO માં આ એકમાં દેખાય તો બીજામાં સેમ દેખાય એવું પોસિબલ જ નથી.
This from literature, sir.
એટલે you are telling truth because diagram is not right.
I'm saying the photo. It's highly. How many angles you take in coronary angiography?
6 views total, sir.
Six views.
Every direction you take.
So 99.99% you are not going to miss like this. આવું તો કોઈ થાય નહીં.
But that 1% can be missed. It is disadvantage of coronary.
We understand what you want to tell us, but
અને
But eccentricity of
IVUS ને પ્રમોટ કરવા માટે આ છે. Otherwise it's not possible. અને પાછળનો સ્લાઇડ તો
Yes.
Another limitation probably that you can put is you cannot see the vulnerability of the plaques.
Yes, that is advantage in IVUS. Yes,
That is a limitation of CAG also, na?
Yes, yes, yes. Okay. There can be observed bias. This lesion, one observer can say 90%, other can say 80%, as already told. This is a vessel foreshortening due to the direction of X-ray source and image interpreter. There is a specific phenomenon I want to highlight, is Glasgow phenomenon. This is a positive remodeling phenomenon. It says lumen area of atherosclerotic human coronaries remain constant until the percent of stenosis exceeded 40%. These plaques are particularly prone to rupture and missed by angiography. Means that when plaque area is, although plaque area is 40%, angiography can be normal and stenosis start after the plaque area exceeds more than 40%. It is a physiological modification of coronary wall to give sufficient blood supply to myocardial.
Phenomena શું છે?
Pathological phenomena, sir. Initial pathogenesis of atherosclerosis doesn't
I got, but what is the phenomenon?
doesn't involve And second thing, angiographically unrecognizable left main coronary arteries can be missed in coronary angiography due to the large size of left main coronary artery. If it is diffusely diseased, and angiographically we can miss the lesions in left main coronary arteries sometimes. This same correlate with reference segment analysis and relative stenosis. I can say if proximal reference segment is also stenosed and the lesion segment is also stenosed, which can misinterpret the diagnosis of stenosis. So, what is the solution? We need the intravascular tomographic visualization of lumen area and vessel wall architecture. There are advanced catheter-based coronary angiographic imaging techniques such as IVUS, OCT, angioscopy, and spectroscopy. For this. So, coming to the IVUS, IVUS has become the leading tool for coronary imaging due to advancement that have enhanced its resolution and penetration. The first true IVUS system was designed by Bohm and is associated in Rotterdam in 1971, invented as a technique of visualizing cardiac chambers. The first transluminal images by York and his associates in 1998. IVUS is now capable of accurately assessing plaque characteristic, volume and constituents and measuring the coronary artery dimension including MLA, which aids revascular decisions. There is a key role of IVUS in optimizing PCI, especially in complex lesion. IVUS is superior to OCT in assessing vessel wall and remodeling pattern. I will compare the IVUS versus OCT in subsequent slides. Positive vessel remodeling can be detected by IVUS, which is linked to late stent thrombosis after drug-eluting stent implantation. So, coming to what is the difference between IVUS and OCT? OCT offers better resolution than IVUS, and it is used to assess plaque characteristics and optimize PCI and identify vulnerable plaques. However, the limitation of IVUS is it restricts assessment of plaque thicker than 1.0 to 1.5 mm. OCT excels in detecting thin cap fibrous atheromas, macrophages, neovessels, and distinguishing red and white thrombus. OCT is used for evaluating vessel wall injuries post PCI such as intimal tears, dissection, tissue prolapse, and incomplete stent apposition, allowing for procedure optimization. OCT also outperforms IVUS in detecting uncovered stent stress and assessing the thin neointimal follow-up after drug-eluting stent implantation. So here are technical comparison between IVUS and OCTs. So in which categories IVUS is better over OCT? For deeper penetration, assessment of vessel remodeling, plaque value measurement, and for assessment of larger vessels, IVUS is better. Stent expansion and apposition, IVUS is better than OCT. And main thing is there is no need of contrast in IVUS, while OCT requires contrast. So in patient with renal dysfunction, IVUS is better. There is a newer concept called no contrast angiography or no contrast coronary intervention. IVUS is widely used because it doesn't require contrast and we can assess the pathology. So here we can say IVUS and OCT images. So coming to the IVUS consists of console, a monitor, processor, and storage device. Second is motor drive. This is motor drive unit. It controls the rotation and pullback of the catheter. And third is IVUS catheter, which is transducer mount. There are two types of catheter. One is mechanical and phase array catheter. Mechanical is the most common. Here only single transducer is placed on element and which rotates at the very high RPM and takes the images of the vessel wall. And phase array catheter, there are multiple circumferentially arranged transducers placed on single catheter. So, after interpreting the IVUS images, here you can see the normal IVUS images of the vessel wall. Here you can see lumen of the coronary artery is the dark. The intima is brighter. Here the I stands for intima, is a brighter. After that intima there is a media which is much darker images in IVUS. And after media there is an adventitia. Here this adventitia is a brighter image. So in pathogenesis, atherosclerosis, which is disease of intima, lipid fibrous tissue with calcium in liquid and intima thickness increases. This is a lipid pathogenic plaque. What we have to consider in IVUS imaging assessment? We can consider do the plaque assessment like morphology, composition, distribution. IVUS extends our capability to visualize beyond the lumen and access the characteristics of vessel wall. Visualization of small splits in plaque after angioplasty can be assessed in IVUS. There are some important measurements which to be taken in IVUS image. I will name some of it. That is reference lumen area, stenosis lumen area, the atheroma plaque area, and plaque burden, and percent area stenosis. All these are the technical terms for assessment of coronary lesions. Here, the first image, this total, you can see here is a lumen area in red. Secondly, extra elastic membrane area in green, which is a normal, to be considered normal area for vessel. And by subtracting those, we can get here plaque areas. So, while analyzing plaque, the main thing is plaque echogenesis we have to consider. There are three types of plaque. There is a soft plaque, mixed plaque, and calcified plaque. The equation soft lesions are atheroma, less echogenic are soft lesions. Atheroma are less echogenic than adventitia. Echodense fibrous lesions are same echogenicity as adventitia, and hyperechodense are calcified echogenesis. We have to differentiate between soft, fibrous, and calcified lesions in IVUS. So here in this image, you can see the soft plaque. It is hypoechoic, not as bright as the adventitia. Soft refers to low echogenicity. There are differential of soft plaque like necrotic zone within plaque, intramural hemorrhage, thrombus, and blood stasis can mimic the soft plaque. Second is fibrous plaque. Fibrous plaque is a stable plaques. They are as bright as or brighter than adventitia, hyperechoic. Majority of atherosclerotic lesions are fibrotic. They are stable plaques. Very dense fibrous plaque may cause so much acoustic shadowing that they can be misclassified as calcifications. So third is calcified plaque. Here is you can see clearly see hyperechoic dense calcification. In IVUS we have to measure the calcium arc, that is percentage of circumference of vessel wall calcium is occupied during percutaneous coronary interventions. So main use of IVUS is to identify the vulnerable plaques in clinical practice. These are different type of vulnerable plaques. These have evolution for eccentricity, positive remodeling. These can be ulcerated plaque, thrombosed plaque, and calcium nodule with spotty calcification. This can be the vulnerable plaques. So here you can see the IVUS in unstable coronary artery disease. Here you can see the second image. You can see the ulceration of the plaque, which is very high risk for new thrombus formation. So second thing is eccolutions can be due to thrombus, intraluminal or intima eccolution mass having layered located labyrinth and speckled with necrotic or lipid-rich area. Second is ruptured plaque. When plaque ruptures, it can form the cavity-like structure. In second image you can see when the split plaque contains cavity that communicates with lumen with overlying residual fibrous cap segment. This is ruptured plaque. And this is a thrombus containing thrombus with necrotic core with split of plaques.
क्या split क्या है?
This is split jet also. Thrombus is one of the most difficult tissue types to identify by IVUS. The sparkling pattern on real-time IVUS imaging. Presence of microchannels, echo density less than 50% of surrounding adventitia. Deep calcium circle used at correct diagnosis of thrombus. Sometimes globular or cauliflower-like appearance can be there. Identification of thrombus after stenting may take some time wider to prevent instantaneous stenosis. In this image, you can see the blue line, the outline on thrombus.
After stenting मतलब?
This is a stent. After stenting, there is protrusion of thrombus. We
Oh.
can identify that thrombus in IVUS and can take necessary actions. So we can identify extravascular and intravascular hematomas in IVUS and coronary artery dissection. The main use of IVUS is post-stenting analysis of the lesion. This is important. Three things we have to see. There is well-apposed stent or not. If stent is not touching the wall, it is incomplete apposition. It is well-expanded stent or not, touching the wall but not expanded. These are more dangerous than malapposition and cause stent stenosis. And third is HTL. Here you can see the dissection should be identified post-stent by IVUS. These are some technical terms of endpoint of stenting IVUS. So, should we do IVUS in all pre-PCI patients or not? This is the main question. It is, we don't need to do IVUS. It is much inferior to FFR as FFR is more physiological. FFR is preferred to assess lesion significance whenever required over IVUS. But when we should use IVUS, here are points. In left main stenting, according to every literature, left main stenting should be done under IVUS guidance or OCD guidance only. In MINOCA, myocardial infarction, non-obstructive coronary arteries, to assess mechanism. We have to use IVUS in restenosis to explain the underexpanded states or any previous complication. In acute coronary syndrome, moderate lesion is hazy or eccentric or irregular border, looking for plaque rupture or thrombus or plaque ulceration. Last time, sir, I have asked a question to me like the young patient, 36 years old patient, come to with enteroalumni, successfully thrombolized. After angiography, there was no significant lesion. What to do next in that patient? That case. So in that case, IVUS can be beneficial to assess the plaque morphology and whether to stent or not. In that cases, IVUS is beneficial. The suboptimal angio result, we can use IVUS. In case of heavily calcified lesion, to rule out stent expansion and other, we can use IVUS. So IVUS before PCI, when we to baseline, when to use before PCI, baseline plaque composition, vessel size, and confirm CAG severity, IVUS can be used. So coming to the studies which gives the IVUS as the modality of choice. The ADAPT-DS is the largest study done till date. It is a randomized study between IVUS versus no IVUS use. It consisted 8,582 patients. The IVUS arm was 3,300 and angiographic arm was 5,100. Clinical follow-up was at 30 days, 1 year and 2 years.
So these are acute coronary patients or?
Also, they this ADAPT-DS actually dual integrated study. In that study, they included IVUS and they analyzed that patient also. They taken all patients.
So patient at least had an acute coronary event. ये बता enroll करेंगे.
Acute coronary plus chronic stable angina also.
So those who haven't had any acute event, they were also enrolled in this study.
Yes. Overall assessments. So here you can see there is a 35% reduction in major adverse cardiac event in the IVUS arm. That is, IVUS used as only 4.9% of the patient with major adverse cardiac event, and no IVUS used at 7.4%. Same findings are correlated with definite stent thrombosis, myocardial infarction, and clinically driven target pressure reversal is less in IVUS arms. So, how IVUS changed the procedure in this guideline? Around 74% of the patient has a change in strategy during intervention, like change in balloon size and change in stent size.
That is a huge number.
Huge number. But the only change in strategy, that's why it's not significant. They only need reduction in MSE. But there is a very high number, and here you can see the what changes are done after IVUS. There is a larger balloon stent. These are no stent, higher pressures, under expansion, malapposition, additional stent, and other changes. There is a large number, 74% of the patient need a new mechanism after IVUS. So, what guidelines statements about IVUS. The ACC, AHA, SKY and ESC guidelines on myocardial revascularization provides class 2 recommendation for IVUS with evidence level varying by indication. OCT is not included in US guidelines due to limited clinical data, but he has class 2 recommendation European guidelines. So here are the guidelines for IVUS. You can say IVUS is recommended from all guidelines.
These are which years guideline?
2018, sir.
18.
18, 19. And latest OCT can be next in guidelines. And OCT is only recommended in ESC guideline. But currently in clinical practice, we prefer OCT whenever available over IVUS. And specific lesion, only IVUS can be used. So there is advancement in IVUS technology. This is a VH IVUS, that is real-time image assessment with color coding. VH IVUS provide colorized tissue map of 4 tissue types: necrotic zone, dense calcium zone, fibrozone, and fibrofatty zone. Here in this image you can see all 4. Green color is fibrozone, yellow color is fibrofatty zone, red color is necrotic zone, and white color is dense calcium zone. Is for
So sort of tissue Doppler.
yes, tissue Doppler. It is automatic image calculation from the machine.
એટલે આનું કંઈક બીજું નામ હશે ટિશ્યુ ડોપલર તો મેં ઇકોના નામ પરથી લીધું
VH IVUS, virtual histology IVUS.
વર્ચ્યુઅલ હિસ્ટોલોજી
Virtual histology name is this only VH IVUS. This, and here you can see the image from the monitor. This is the image from the monitor only.
Are we doing this?
Actually, this procedure and reading is done by cardiologist.
Yes.
Or some radio technician or radiologist.
Cardiologist only that comes in limitation of IVUS.
Limitation.
I will come. But actually, sir, it is very simple. If you can get, it can clearly say green is fibrous, red is necrotic, or we have to identify the red lesion to see the vulnerable plaques. Like in D image, it is a thin cap fibroadenomatomas with large of red spots. It is a vulnerable plaque. And during A image, there is adaptive intimal thickening, so no need to worry. It's for gross analysis only, sir. And second,
What percentage of necrosis would be there to worry?
sorry, sir.
In the plaque, what percentage of plaque area should be necrosed to get worried?
Percentage, sir, but exact
Suppose
percentage.
D, you are saying D is having almost 70 to 80% of necrosis, right? In C, there is almost 30-40%.
Yes.
So C is worrisome or not?
No, sir, it is a large thick cap and thin cap is there. Cap is main.
Cap is main.
Cap is main. But also it is thick cap. It is vulnerable only. But we have to don't need to any intervene. Here you can intervene.
If you are saying vulnerable and you are not intervening, what is the fun of saying vulnerable?
It's more prone to rupture.
Okay, what is about E, where the necrosis is not that much, but necrosis is almost touching the fibrous cap? Is it vulnerable?
It is more dangerous. I think.
It's vulnerable.
Immediately.
It's like calcium reducer.
And F
It's a fibrocalcium plaque only.
oh, calcific.
Nothing. And there are spotty calcification. Spotty calcification.
So which tool is better? IVUS is better or CT coronary angio is better to define a vulnerable plaque?
IVUS is better, sir.
IVUS is better?
Yes, but it's costly. You can't use.
Is there any correlation between these two? Suppose if I do a CT coronary angio where I find a vulnerable plaque and if I put IVUS in myself,
IVUS take the image from inside of coronary artery.
exactly, but does there any correlation, any study where after that you decide or you not to decide what to do? How can check? देखना पड़ेगा.
CT coronary versus IVUS.
Yeah, because CT coronary in last decade they have been promoting so much to
Yes.
check all these things, right? Because if I send a patient
Yes.
to you કે જેમાં બે ત્રણ plaques છે and they are not calcified and radiologist has reported there's a vulnerable plaque.
Okay.
The patient is absolutely asymptomatic, 35-year diabetic, dyslipidemia, obese male. Will you do IVUS in this?
Plaque is one vulnerable. We have
CT માં લખ્યું છે vulnerable છે, radiologist છે લખ્યું, cardiologist છે લખ્યું નથી. What you will do? Is is a smoker, a corporate,
No risk factor and clinical history and symptoms.
is absolutely a symptom.
Based on CT directly you will go for intervention or you will
No,
still
sir.
go for IVUS.
And then how will you approach? Because આખી દુનિયા આવા જ પેશન્ટ થી ભરેલી છે અત્યારે. અને જે કદાચ યંગ એજ માં કદાચ ઉકલી જાય છે એ બી કદાચ આ જ કેટેગરીમાં ફોલ થાય છે. તો આમાં કઈ રીતે અપ્રોચ કરશો? સપોઝ ઇફ યુ નીડ ટુ પ્રિવેન્ટ અ સિંગલ ઇવેન્ટ ઇન સચ પેશન્ટ, બરોબર? એક તો સિટી કોરોનરી એન્જિયો બધા કરાવતા નથી, કરાવે તો માનતા નથી.
Your study is clinical coronary IVUS versus CT coronary.
Yeah, so
You have to correlate that.
એ લેવલે કઈ છે કઈ પ્રોગ્રેસ, કઈ ગાઈડલાઈન કશું
देख लेता हूँ, sir.
દેખો જરા બતાવો.
Or as a cardiologist, we don't go to CT.
I know, that is why I am pushing you.
That's why, sir.
Right? Because 30-35 વર્ષના રિસ્ક ફેક્ટર વાળા પેશન્ટ જે સિમ્પ્ટોમેટિક નથી એની અમે કોરોનરી એન્જિયોગ્રાફી ઇન્ટરવેન્શનલ વાળી ક્યારે નથી કરાવવાના સીધી.
Definitely, sir.
Right? What may definitely I have started doing city coronary angio so frequently now that I am surprised to see the level of atherosclerosis which is coming nowadays.
Okay.
Right? And the people are starting reporting also very nicely and they are so much confident कि ये तो vulnerable है sir, इसका कुछ करो, but इसका हम कुछ करते नहीं.
Yes, sir. We need that adopted.
देखना कुछ है तो है.
Yes. And coming to the for longitudinal stent placement, this is a important image interpretation of stent placement. We should take care that stent should not the age of stent should not on the necrotic core. If it is a high chance of thrombosis here. So IVUS can be used for longitudinal stent placement so that stent position can be normal, or we can put on the second stent here to prevent the further thrombosis.
But ये तो OCD भी दिखा देगा.
OCD भी दिखा है, पर उस IVUS. So what are limitations of IVUS? It's a very costly procedure. It has a long learning curve, as you say, sir. It's very difficult. In here we can see the clearly images, but in actual practice it's very difficult to interpret the images.
What is the present cost?
Around, sir, IVUS at 1.5 to 2 lakhs per catheter. Procedure status. And accuracy, the image
Must not be covered in my IVUS mandate.
yes.
Needless to say.
Mediclaim માં તો
Medical માં છે.
Medical method.
પણ એનું interpretation I think may be very difficult.
OCT interpretation is very easy, sir.
Very
I
simple.
think તમે લોકો કરો છો IVUS આને?
OCT prefer करते हैं, sir. IVUS hardly एक दो patient में की ज़्यादा.
But IVUS, Dr. Kamal Sharma was doing IVUS so much
Yes.
in the last decade. એને પૂછી શકાય detail.
पर सर और IVUS का एक एडवांटेज है कि जो CKD के पेशेंट है उसमें भी सर नॉन कॉन्ट्रास्ट एंजियोग्राफी है तो उसमें IVUS तो और आगे जा रहा है सर.
But उसमें अगर एक्यूट कोरोनरी सिंड्रोम में प्राइमरी प्लास्टिक के लिए ले रहे हो जहाँ पे 100% ब्लॉक है तो IVUS से क्या करो?
नहीं स्मॉल कॉन्ट्रास्ट एंजियोग्राफी द टर्म चेंज.
Yeah, right. So उसमें IVUS का भी लिमिटेशन हो गया.
यस.
दोनों करते हैं IVUS और OCT both are
हाँ. पर मेन OCT is simple, easy to interpret sir. OCT is preferred over IVUS.
वो दोनों
Unless
VIP
specific
में होता है.
indicated sir.
उसका सेपरेट अलग मशीन है.
हाँ
हाँ,
वो बता रहे हैं.
एक टोमोग्राफी છે એક અલ્ટ્રાસાઉન્ડ છે.
The accuracy can be hampered when the direction of imaging plane is not perpendicular to axis during maybe tortuous and curved vessels. There can be risks like coronary spasm, dissection, perforation. Although rare, but there can be complications. So concluding today's seminar, intracoronary imaging has significantly advanced in intervention cardiology with the choice of modality often depending on the lesion location. IVUS is more effective for left vein stenting, while OCT excels arteries with minimal lumen area less than 3 mm² due to its superior resolution. However, for evaluating intermediate coronary stenosis, FFR is the preferred as MLA cutoff values from IVUS and OCT have moderate correlation and accuracy. Both IVUS and OCT are safe and practical for use in modern cardiac catheterization lab, with experienced operators able to perform imaging quickly and with minimal complications. While each modality has its strengths and limitations, using both together could be beneficial. Future developments in intracoronary imaging are expected to include core registration with angiography and advances in hybrid and molecular imaging, which will likely to offer deeper insight into coronary artery disease and